Hi, everybody. I wanted to briefly cover restraint use since we did not cover this in class. We usually cover this in lab, but we had our snow day and weren't able to do it. Restraints are something that we use only as a last resort in hospitals and care facilities now. We've Research has shown us that restraints actually cause more harm than good, and they don't prevent falls. Uh, Oftentimes, restraints would actually cause falls. When we used to put four bed rails up, people would climb over them and fall and have a worse fall than if we didn't have the bed rails up. So, some of the things we do for patient safety, because we are aimed at last resort using restraints, but we still have a top priority as nurses of preventing falls, is orient the patient to their surroundings. We know that people who are well oriented to their call lights, to how to get help in the room, to we put the proper slippers on, not slippers. We haven't used slippers. We put the proper non-skid hospital type footwear on them. We know that they're at a far lower risk of falling. So make sure you leave a light on for them if they are going to be, at nighttime. Make sure that you answer the call light quickly once they put the call light on. You can often arrange for a bedside commode. Besides orienting people to their surroundings, making sure they can use their call lights, as we've talked about, we want that bed to be in the low position, the brakes on the bed, and you want to do hourly rounding. This is a policy now in most hospitals anyway. The hourly rounding, we will address if the patient's position, do they need to be repositioned? Do they need help with that? Do they need to go to the bathroom? If so, every hour we need to address these things. It's I think it's called potty, position, possessions, and I can't think of the other P right now, but I will. Um, it's We want to see if they need to go to the bathroom, potty. We want to see if they need to change positions. Are there possessions where they can get to them? And the fourth P is pain. Find out if they have any pain and if they need any kind of relief for that. If we do that, we find that when we do that every hour during our rounding, that there are far fewer falls, patients are much more satisfied, and there aren't as many call lights going on, so we're able to get to the ones that are on in a more timely manner. So those are some things we do to help reduce falls in the light of the fact that we no longer use restraints except for emergencies. When we do use restraints as um, a last resort, it's often with patients who are ventilated and they are in and out of consciousness, and they will sometimes wake up and pull out their tubes. Now, if we had a patient on a ventilator who was completely unconscious and was not moving at all and not able to move, we would not restrain them. We would probably, I have unrestrained those folks. But anybody who is unconscious because they're being sedated, they can come in and out of that sedation frequently, and they can very well reach up and pull that tube out. So that's one of the times that we do use restraints. The most common restraint that we use is a wrist restraint in hospitals and facilities, and that is the most common reason is for patients who are ventilated. And we know that when they wake up, your first impulse when you wake up is, if you've got anything in your mouth or anything in your face that's bothering you, you want to grab it and pull it out. And we know that this happens, so we keep people restrained when they're on ventilators. Sometimes you need to restrain children, and they've got an example here of the elbow restraints that can keep a child from pulling out their tubes out of their nose or mouth. What was I going to say? Sorry, guys, I lost my voice there for a minute. When we do have to use restraints as a last resort, we need to make sure that we can get our fingers inside the restraint, between the skin and the restraint, at least a couple of fingers, 2 to 3, because we don't want the restraint to be so tight that the patient loses circulation. We need to do hourly checks on the restraints to make sure that circulatory checks to make sure that they've got good capillary refill, even with the restraint, and that they're warm and able to move those hands. and we're going to use them for the minimal amount of time we can. As soon as the patient is oriented enough not to pull out the tube, not to cause danger to themselves, we're going to remove that restraint. We need to have an order every 24 hours from a provider to renew that restraint. They need to assess if that restraint is still needed and write that order. We do, in an emergency, have the ability to put a restraint on without an order, but we need to immediately call and get that order from the provider. It's not something that we can go with. We have to have that order right away to continue them. And sometimes this happens if we have someone who becomes very disoriented and very agitated and is a danger to themselves or to the staff. Sometimes we need to briefly put them in restraints. If we do that, we have to call the provider right away and let them know we did that and get an order for that, and that needs to be renewed every 24 hours. And then we need to take measures to get that restraint off. We need to start looking at things that will work to allow us to take the restraint off. Sometimes people need, if they just have a family member stay with them at night, they will do fine without restraints, and they won't try to fall. Sometimes the nightlight will fix the problem. Sometimes some music on that just kind of gently puts them to sleep, so when they awaken, they're not in fight or flight mode. Bed alarms are the number one thing that we use, though, for folks who are disoriented and want to get out of bed. We will put a bed alarm that will beep really loud for us so we know they're trying to get out of bed, and we will come to get them before they fall. The hourly checks on them are very effective to keep people from getting up and trying to go to the bathroom. Sometimes diversional activities, games, books, it helps. It's helpful too to walk people in the halls, get them a little bit physically tired, so maybe they'll go to sleep, and consider that on a regular basis. Sometimes we move people closer to the nurse's station or put a camera on in the room so we can watch them. Sometimes we'll have a sitter. There's lots and lots of alternatives to restraints. We just have to know what they are and use them, try them. In your book, there's a whole box on this, box 28-7, and for your practice and for tests, be familiar with that box. Here's some of the hazards that are associated with restraint use, and this is why we don't use them anymore. Like we used to put them on everyone, it seemed, and it's really, really positive that we've reduced their use to minimal. We know that people develop delirium and depression at higher rates if they're restrained, and there's actually increased serious falls when they try to get over bed rails. They can develop contractures because they're not using their arms. They're not using their arms or feet sometimes if we've got their legs restrained. They can also experience respiratory problems and aspiration, and people have suffocated by being restrained, and they'll turn into a certain position, or when we used to use the vests a lot, sometimes those vests would be too tight around their midsection and would actually make it difficult for them to take a deep breath. So I think that's all I wanted to say on that. I will say in psychiatric settings, if you have a patient who's restrained, they actually have to be checked every 15 minutes. You can't go longer than that without checking on them. So in psychiatric settings, they often will use chemical restraints rather than physical restraints. And chemical restraints are drugs. Basically, if you've got someone who's very agitated and a danger to staff or a danger to themselves, they will use medications. And we will do that in acute care as well. It's just not as common as in the psychiatric setting. And I think that was all I wanted to tell you. I think we covered the rest of this in class. I just wanted to make sure that we covered restraints, make sure you're aware of their use, read your book on this, read about safety, read about alternatives. This is something you will use in your career and you will see on a future test. All right, thanks guys.